solidarity and support to those countries who may now be experiencing increased.
Thank you, Dr. Ryan. The next question, it might have to be the last because we're coming toward the end of the time allotted, goes to Helen Branswell. Helen, can you unmute yourself and go ahead?
Hi, thanks very much for taking my question. I apologize, I missed the beginning of the briefing, so you may have covered this, but since Dr. Fowle is there, I would like to ask if he could give us any kind of a sense of how things are going on the ground in Ecuador province with the new Ebola outbreak. Numbers are available from the Ministry of Health in DRC, but we're not really getting much in the way of detail on how well or not well the containment effort is going. Thank you.
Thank you, Ellen. Good to meet you again. I have been interacting so many times around Ebola in North Kivu. And as you rightly said, this new outbreak is happening in Equateur, which is a different context with very limited resources and difficulties to move from one area to another. You have to move by boat, by helicopter to make sure that you can implement the right intervention. So in terms of operation, we have now 7 health zones affected, although 6 are only active right now. It means decentralizing operation to making sure that we have all the necessary capacity in terms of investigation, in terms of isolation, treatment, contact tracing, and vaccination. And so we have a good team on the ground composed by Congolese, WHO staff we already had in Congo, some from North Kivu, others from Kinshasa, and a number of partners like MSF, UNICEF, IFRC working around various pillars. So we still have some challenges in terms of alert, mainly alert related to death body, because it's very important to make sure that our surveillance pick up all the alert, not only from the health facilities and alive alert in the community, but also dead body. And so we are scaling up, still have important gaps in terms of operation.
Cases in 21 health areas across 7 health zones. So while the numbers are very low, dispersed, and 5 of 7 of those health zones have had cases in the last 4 days, which means the disease is active, it's not old. So what we have is active disease in 5 health zones across a wide geographic area. Again, worrying is that there are still 9 cases who are still in the community, and there are real challenges in terms of community engagement and convincing people to come for care in Ebola treatment centres. And of the overall period in terms of exposures, and again, this may go back to the whole issue of case finding and contact tracing and getting the information you need to know where and what the transmission factors are. It is interesting to me that in this case, in the most extreme situation of logistics, probably in the world, the data that comes in daily from the surveillance teams, tells us that for the people who've been exposed over the last 21 days, for example, the exposures, but over 1 in 3 people have been exposed at a funeral event. Just over 10% have been, 11% have been exposed through nosocomial or in the healthcare system, and a lot further number of people have been exposed in a family context. So the information you glean from case investigation and contact tracing tells you who's at risk. And we're able to say for a very remote part of Congo, that a big risk factor in this particular clusters of cases is funeral practice, and we're working very closely with communities then to really work with them on the funeral process and on engaging with them on how to make that practice safer. It is very hard to engage in generalities. When you work with communities, you must be able to engage on specifics. Getting good data from case and cluster investigation gives you the specific data that allows you to identify the risk factors and then engage positively with communities on how to reduce those risk factors. This is epidemiology and public health in action. If we can do this in a remote part of Congo, if we could do this in the middle of a war zone in North Kivu, we can do this for COVID-19. It is not impossible. Many countries have demonstrated that all over the world. So I think even though we don't have perfect data from the field, and Soze can speak to some of the challenges we face logistically and operationally, the fact that we have these data, we know where our problems are in the field. We know where our hotspots are. We know what's driving transmission in those communities, and that allows us and gives us the basis to intervene and to make a difference. So while the situation in Congo remains of concern, what reassures me at the moment is that we're improving in community engagement. There are many partners on the ground. And again, we'd like to thank our partners, particularly in the Red Cross movement and others who, once again, are working with local teams in terms of safe and dignified burial, our colleagues in UNICEF who are working on communications, our colleagues in the UN system working on coordination, the World Food Programme working on logistics and support to base camps, but most of all, the frontline health workers of Congo, the Congolese doctors, nurses, hygienists, community engagement specialists who make up the vast majority of the front line in this response. And again, our thanks to the government, the Ministry of Health and the Institut National de Recherche Biologique, INRB, for their leadership in this response.
And thank you, Helen, for your question, which really ties together much of what we have been trying to get across today. And now I'll hand it over to Dr. Tedros for final words.
Yeah, thank you. Thank you to all who have joined today, and look forward to seeing you. I think the next will be on Thursday. Thank you.
Hello, everybody. This is Margaret Harris at the WHO headquarters in Geneva. Welcome to our COVID-19 press briefing today, this Monday, July 20. As usual, we'll be providing simultaneous translation in all 6 languages, all 6 UN languages, plus Portuguese, and you may also listen in Hindi. Note, owing to the way Zoom is set up, you will have to go to the button marked Korean to access Arabic. We have been having some connectivity problems today, so we apologize if there are any problems. We will ensure that we keep it going on Zoom, but there may be some problems with our social media connection. And now I will hand over to Dr. Tedros. Dr. Tedros, you have the floor.
Thank you. Thank you, Margaret. Good morning, good afternoon, and good evening. Although people of all walks of life are affected by COVID-19, the world's poorest and most vulnerable people are especially at risk. That's true of indigenous peoples all over the world, in urban or remote areas. There are up to 500 million indigenous peoples worldwide in over 90 countries. Indigenous peoples have unique cultures and languages and keep deep relationships with the environment. Like other vulnerable groups, indigenous peoples face many challenges. This includes a lack of political representation, economic marginalization, and lack of access to health, education, and social services. Indigenous peoples often have a high burden of poverty, unemployment, malnutrition, and both communicable and non-communicable diseases, making them more vulnerable to COVID-19 and its severe outcomes. Although COVID-19 is a risk for all indigenous peoples globally, WHO is deeply concerned about the impact of the virus on indigenous peoples in the Americas, which remains the current epicenter of the pandemic. As of the 6th of July, more than 70,000 cases have been reported among indigenous peoples in the Americas, and more than 2,000 deaths. Most recently, at least 6 cases have been reported among the Nahua people who live in Peruvian Amazon. WHO's Regional Office for the Americas recently published recommendations for preventing and responding to COVID-19 among indigenous peoples. The WHO is also working with the coordinator of indigenous organizations of the Amazon River Basin to step up the fight against COVID-19. Clusters